Okay, we should have folks coming in slowly. Thank you everyone for joining. We'll be getting started shortly with a few announcements.
Gracias a todos por conectarse. Vamos a empezar en un momento más con unos cuantos anuncios.
Sorry, folks, just give me a minute.
I see one of an attendee has their hand raised. I can't see exactly who. But if you'd like to ask your question, you can go to the bottom of your screen and click Q&A. Because we have so many people joining today, we just have a Q&A enabled.
Veo que uno de los participantes tiene la mano levantada, entonces si tienen alguna pregunta, por favor, en la parte baja de su pantalla pueden usar la opción de preguntas y respuestas. Como vamos a hacer tantas personas, tuvimos que habilitar nada más esa función.
Okay, I think we're good and we can get started. Thank you everyone so much for joining, and I'll pass it to my colleague Terry to kick us off.
Hi, good afternoon, everyone. I am Terry Wilder, and I am going to pass this over to Lilia to give some opening information about interpretation.
Thank you. Buenas tardes. La reunión de hoy tiene interpretación simultánea en inglés y español, la cual se va a activar en unos momentos más. Good afternoon. Today's meeting has simultaneous interpretation in English and Spanish, which will be activated momentarily. Cuando se active la función, bueno, voy a estar aquí junto con mi cointérprete Alexia para asegurarnos que todas las personas puedan participar, comunicar y entenderse en el idioma en que se sientan más cómodos. We are here to ensure that everyone participating may communicate in the language in which they feel more comfortable. However, we cannot do it alone. Sin embargo, necesitamos el apoyo de todos. Para los que van a presentar hoy, nos pueden ayudar hablando a un ritmo moderado, en voz alta y clara. Si necesitamos que hablen un poquito más despacio, se los haremos saber por medio del chat. For those that will be presenting today, you can help this effort of creating an inclusive space by speaking at a moderate pace, loud and clear. And if you need to speak more slowly or loudly, we will let you know through the chat. Para todos los participantes, por favor, no sufran en silencio. Si la interpretación no está funcionando o tienen problemas técnicos, nos los pueden hacer saber por el chat. For all the participants, please don't suffer in silence. If the interpretation is not working or if you're having any technical difficulties, please let us know in the chat so we can assist you. Y para acceder a la interpretación, cuando activen la función de interpretación, ustedes van a ver un globo terráqueo en la parte de su pantalla, le dan clic ahí y les va a dar la opción de escoger el idioma en el que gusten participar. Si nos acompaña desde un teléfono inteligente o una tablet, le va a dar clic en los tres puntitos en la parte inferior derecha de su pantalla. Eso va a abrir un menú con la opción de interpretación de idiomas y entonces va a poder seleccionar el idioma en que guste participar. Nada más asegúrese de darle clic en finalizado para que se active la función. Next slide. When they when they start the interpretation function, you will see a globe at the bottom of your screen. You may click on it and you will have the option to choose the language in which you want to participate. If you're joining through a smartphone or a tablet, you will click in the three little white dots at the bottom right of your screen. That will open a menu with the option for language interpretation, and then you will be able to choose the language in which you want to participate. Just make sure to click where it says done for the function to be activated. Y con eso pueden ahora los anfitriones iniciar la interpretación. And with that, the host may now start interpretation. Thank you.
Okay, thank you so much.
All right. So good afternoon, everyone. Again, I'm Terry Wilder. I use she, her pronouns. I am the HIV and aging policy advocate at SAGE. And welcome to Demystifying the Older Americans Act for people living with HIV. This is part 1 of 3 of SAGE's Demystifying the Older Americans Act webinar series. If you're unfamiliar with us, SAGE is the world's oldest and largest organization dedicated to improving the lives of LGBTQ plus elders. We were founded in 1978 and we're headquartered in New York City. SAGE is a national organization that offers supportive services and consumer resources to LGBTQ plus older people and their caregivers. We also advocate for public policy changes that address the needs of LGBTQ plus elders, including people aging with HIV. I'd first like to thank all of our co-sponsors. They're all shown on this slide. We appreciate their support in getting the word out about this webinar series. And if you heard about this webinar series through one of them, be sure to thank them for sending the message to you. So our agenda this afternoon is our welcome. So I just did a little bit of a welcome. We'll then move on to a discussion about the Older Americans Act, sharing the basics of that for you. Then we'll have a conversation about how the Older Americans Act relates to people living with HIV. We'll then move on to an activity about the Older Americans Act in the services. We will end with a question and answer period, and then we'll close with some final remarks of some resources and just a reminder about the 2 remaining webinars. Just a word about some group agreements and norms for our webinar. So you'll notice that the chat function is closed, but the question and answer tab is open. So when you're using the Q&A, if you could please note the person your question is directed to. So you could put E for Emma, V for Vince, A for Andrea, T for Terry as an example. As you heard, we are offering Spanish interpretation today around and closed captioning. And this is our commitment to language justice so that folks can have an opportunity to access this information. As you're putting in any questions in the question box, please keep in mind the impact that you have on others. You may have an intent in your question that may not be relayed. So it's really important to keep in mind the words that we use because they may impact people differently, may come across as disrespectful. So our commitment to one another is to treat everyone with respect, valuing diverse perspectives, and refraining from personal attacks or disrespectful language. And then just a final reminder during this webinar to maintain confidentiality. Folks may, in their question, share a little bit of personal information for context for their question. So we ask that everyone please keep any personal stories or sensitive information shared during the webinar confidential unless explicit permission is given to share outside the group. So thank you all for taking the time to hear these group agreements and norms. So here's our webinar team. As mentioned, I'm Terry Wilder. The second picture over is my colleague Cam. Then next to that is Emma. Then we have one of our speakers, Andrea Callow. And then we have our guest speaker, Vince I'm sorry, Vince Chrysostomo, who will also be giving opening remarks. So now I'd like to turn it over to Vince. Vince has been an HIV and AIDS activist for more than 35 years in the United States and abroad. He served as an organizer, a peer advocate, a person who does outreach, education. He's trained providers, he's done research, and he's also acted as an executive. He's a current member of the San Francisco Mayor's Long-Term Care Coordinating Council. He's chaired the city's HIV and Aging Working Group, and he served on the San Francisco Dignity Fund Steering Committee. And he currently co-chairs the San Francisco Dignity Fund Oversight Committee. He is the Director of Aging Services at the San Francisco AIDS Foundation and was appointed by the mayor to the San Francisco Human Rights Committee's LGBTQ+ Advisory Committee. So I'll invite Vince to give our opening remarks.
Thank you, Terry. Good morning. My name is Vincent Chrysostomo, as Terry said, and today I'd like to dedicate my remarks to the memory of those we've lost, to the long-term survivors, affectionately known as the AIDS generation, and to those long-term survivors or dandelions who were born with HIV and who continue to live and thrive despite what was once considered a death sentence. It's been a while since I've worked with translation during a webinar, so hopefully I won't speak too fast. But a little bit more about myself. I am a native Chamorro of Guam who identifies as queer and whose pronouns are he, him, and his. I have been living with HIV since 1987, and then in 1989, I received the news that would change my life forever, a diagnosis of HIV. That was followed by an AIDS diagnosis in 1995. The doctors in 1989 told me that I would most likely not live to see the age of 30. Yet, here I am. It's 2024. I'm 63 years old, defying the odds, and so I stand before you, or sit before you on this webinar, as a living testament of resilience and hope. Yet, it wasn't always that way. Since 1996, or starting in 1996, the advancements in medical technology has meant that the life expectancy of myself and other people and older people with HIV has improved. Yet it should be known that older people living with HIV have 3 times the comorbidities of those who are not living with HIV, and those conditions appear earlier, usually starting around the age of 50. We didn't plan to live, so we didn't save for retirement. Today, many of us pay 50 to 70% of our income to rent. At age 65, those of us who are able to secure private disability will age out of those policies and could lose up to 75% of our income. Many in my generation lacked family support and lost the friends who we would grow old with and who would hopefully take care of us. So I returned to San Francisco in 2013. And for the last 10 years, I've had the honor and privilege to serve my community in ways that I had not envisioned. So you can imagine my shock and displeasure to find that despite being in the majority of people living with HIV, I found that HIV/AIDS providers did not have a robust menu of services to meet my needs or the needs of my friends and clients. Traditional aging services providers often had no place for us at the table, and I was horrified to learn that they did not consider HIV to be an issue amongst older adults. And this is in San Francisco, where 74% of people living with HIV are over the age of 50. So it seemed that the policies and systems I assumed would be there for me were not. And it felt like a throwback to the 80s and 90s. Unlike views held in the 80s and 90s, HIV is not just viewed as a gay disease. And in recent times, we have seen significant numbers of people who maybe after losing a partner, a longtime partner, might begin dating again and acquire HIV. Consequently, there is a growing population of older adults living with HIV, living with the virus, who face distinct challenges related to aging and managing their HIV status. So what's an older person, aging activist living with HIV to do? We fight for our lives. We fight for our lives and the lives of others. So some friends and I got together and wrote the San Francisco Principles in 2020. This was to update the Denver Principles from 1983. And for me, the San Francisco Principles are a call to action to mobilize providers, community, and government officials to remember our history, to fight for health, racial, and social justice, to see that the needs of all long-term survivors and older people and all people living with HIV are addressed, especially as their needs change as they age. Also to remember nothing about us without us. And then for me, after 35 years, to get right what I feel that we haven't in the 40 years, or now I guess 42 or 3 years of the HIV/AIDS pandemic. So we want to ensure that future generations will not have to face what my generation has. That was validated on May 17, 2022, when the San Francisco supervisors passed a resolution to support these principles. It hasn't resulted in any funding yet, but that was a start. So in conclusion, the Older Americans Act is a lifeline for LGBTQI plus older adults and older people living with HIV. By providing funding for essential services, promoting equality and non-discrimination, and raising awareness about HIV, the Older Americans Act can ensure that these communities receive the support they need to age with dignity and access to services necessary for their well-being. It is imperative that we continue to prioritize and advocate for the inclusion and protection of LGBTQI older adults and older people living with HIV within the framework of the Older Americans Act. Together, let us work towards a future where every individual, regardless of their age, identity, race, gender, or health status, can thrive and live a life of dignity and respect. I thank you.
Thanks, Vince. Thank you so much for opening today for this important webinar. We appreciate you. So next, I'll invite my colleague, Emma, who is the campaign manager here at SAGE, to present information on the Older Americans Act. Emma's role at SAGE is to work on the implementation of the Older Americans Act across the country. Emma?
Thank you so much, Terry, and thank you, Vince, for your words. So hi, everyone. I'm Emma. As Terry said, I use they, them pronouns, SAGE's campaign manager for Older Americans Act programs. I want to start by going over some keywords that might appear throughout the webinar today. So we're going to return to a lot of these more in depth later, but I wanted to start just with this sort of level setting. So greatest social need. This is a term that's used in the Older Americans Act to mean the need for support that is caused by factors that are not related to economic reasons where you might need support. So that might include physical, mental disabilities, language barriers, or cultural or social geographical isolation. And basically anything that limits someone's ability to perform daily tasks or that might make it more difficult for them to live independently at home. So for example, greatest social needs populations often include, but are definitely not limited to, older people living in rural areas, LGBTQ plus people, people of color, people who speak English as a second language, and many other populations. I also want to highlight Title III of the Older Americans Act, which is really what we're going to be focusing on today. So Title III is the part of the OAA that provides grants to states and tribes and territories to coordinate the services and supports and to advocate on behalf of older people and their caregivers. So this really covers most of the services that we'll be talking about today, which is why I wanted to point it out here. And our advocacy often implicates other titles, but Title III is all about these supportive services. Another thing that we're going to talk a lot about is the aging network. So this is a term that's used to describe the national network of local agencies on aging, on federal agencies on aging, our federal department on aging, and our state departments on aging. And basically, these are all of the agencies that provide services to help older people live independently in their homes. And it's supported by these tens of thousands of service providers and volunteers. An area agency on aging, which I just mentioned, is your local department on aging, though they might not always be called that. So an example of a AAA might be Age Options, which serves suburban Cook County, which is outside of Chicago, or Centralina AAA, which serves the greater Charlotte, North Carolina region. But it might also be your department for the aging. So in New York, it's just called the Department for the Aging of New York City. AAAs often cover cities, but they also cover either one county or more than one county, like Elder Source, which is in Florida, and that covers Duval County, Clay County, Nassau County, St. John's, and a few other counties. So it's not always just one county or one city, but sometimes it's a collection. And a state unit on aging is your state department on aging, again, a part of that aging network. Might not always be called your state department on aging. So there is a Pennsylvania Department on Aging, but there is also a Nevada Aging and Disability Services Division, which is under their Department of Health and Human Services. So we'll dive into finding out who your state unit and your AAA is later, but just want to put that out there so folks have that level setting. Another thing that we're going to be talking about today is a federal regulation or a federal rule, a final rule. So a final rule is a regulation that is issued by a government agency that really guides the implementation of a law like the OAA. The process for issuing a final rule has a few different steps. First, the agency at hand might decide that they need to update a regulation to reflect the current context of the law. We know that aging in the US has greatly changed since the Older Americans Act was first passed in the 60s. So the regulations that govern it should also be updated. The agency will basically draft a proposed rule with help from other governmental entities, and then they will publish that proposed rule in the Federal Register, and then they'll allow the public to submit comments with their feedback on that draft. And then after considering the public feedback, the agency will publicly release the final rule with a summary of the problem that they're trying to address, and then the goal of the regulation itself. And then the agency that governs the Older Americans Act is called ACL, or the Administration for Community Living. And that is our Federal Aging and Disability Administration. So again, we have this thing where this is a department on aging, but it's not actually called the Department on Aging. So now that we have some key terms, we can dive into more of the history, of the OAA and what it actually does. We can go to the next slide. So the OAA was first signed in 1965 by President Lyndon B. Johnson, really to establish community services for older people in America. It was a part of his Great Society reforms. So that also includes Medicare, Medicaid, a few other programs, and then a lot of programs that have since been either eliminated or their funding has been reduced greatly. And the OAA is one of the programs that it originally created. So it really established grants for states for community planning and social services, as well as research for and development projects, and then personnel training in the field of aging to make sure that everybody feels prepared to meet the needs of older folks in this country. You can go to the next slide. So the OAA established this new aging infrastructure that we already talked a little bit about that you can see on the screen. So it created our Federal Department for the Aging, ACL, which is funded through the federal budget and then distributes all of the money to states. There are a total of about 56 state units on aging. So for all the 50 states, Washington, D.C., Guam, the U.S. Virgin Islands, Puerto Rico, the Mariana Islands, and American Samoa. So like I said before, not always called state units, sometimes called something else, but they are that state's Department of Aging. Might be called your Aging and Disability Services Division. It depends. And then below them, we have over 600 area agencies on aging. And these agencies, again, also called AAAs, are really a base for home and community-based services. Sometimes they're nonprofit organizations, sometimes they're a governmental organization, entity, and some states like Nevada, Wyoming, Alaska, some don't have any AAAs in their state, and their state unit acts as their AAA. So there's just that one coordinating factor. So we can see here, I have an example structure of the aging network. We're at the top, we have ACL, then we go into, for example, the Illinois Department on the Aging, which then funds Age Options, which is an example of a AAA, and then Age Options then funds local service providers and programs. So this is an example of a program that they fund around community engagement and meal deliveries for LGBTQ folks, which I wanted to highlight, of course. So these service providers can really be any community-based organization that's providing supportive services for older people that falls under the Older Americans Act, and they contract out with them. So it could be a senior center that provides social programming and nutrition assistance. It could be a benefits enrollment center. It could be Meals on Wheels program that only does home delivered meals. Sometimes these providers do many different services. Sometimes they focus on just one. We can go to the next slide to see another diagram for how it's really funded. So again, we have ACL at the top. They receive funds from Congress, and then they distribute funds based on a variety of factors to each state unit on aging. So we have another example of a state unit on aging, the New York State Office for the Aging, or NYSOFA. And then states can also receive money from their state legislatures, so not just from the federal government, but they will then distribute that money to their AAAs if they have them. So the New York Department for the New York Office for the Aging then sends the money down to the New York City Department for the Aging, which is also called DFTA. And then AAAs they receive both public, similarly to their state units. They receive both public, so government funding, and then also private funding. So they might get money from foundations, from individuals, and other sources. And then they use that money to then contract out with service providers. So we see here the New York Department for the Aging, after all that money trickles down, they hire out service providers like Sage. We have 5 senior centers in New York City, and they provide meal assistance, social programming, employment coaching, wellness programs, and many more. And then states can also use other funding sources again. So they might be able to use their Medicaid funds, they could use state revenue, and then again, things like grants and donations in support of their programs. Okay, we can go to the next slide. So now that we have an idea of what the OAA actually does, or how it's funded and what it was, first started to do, I want to talk a little bit about what it actually does. So the whole goal of the OAA is to support people as they live at home and age independently for as long as they possibly can. It's really to prevent people from entering unwanted and cost prohibitive institutional care, like nursing homes, assisted living, and other facilities like that. It's updated about every 4 years through the reauthorization process. And the majority of programs are really only accessible to people older than 60. And this is going to come up later. And I saw a question in the chat about this. So there is one title of the Older Americans Act that funds services that has a little bit more flexibility. So Title VI programs fund services for American Indians, Alaskan Natives, and Native Hawaiians. And after they meet all of the program requirements, so they say we have X amount of older people in our area, tribal organizations have flexibility to allocate resources to activities and all of the services that we've been talking about, and they get to decide at what age a member is considered an elder and is thus eligible for services. And that's because of social determinants of health. We see that Native folks are dealing with often what's called accelerated aging, where somebody who might be at the age of 50 might resemble a non-Native person who's 75, and they might have a little bit more in common than a non-Native person who is under the age of 60. So you don't always have to be over the age of 60 to be eligible for tribal aging services. And we'll talk about this a little bit more later, because I did see a question about this in the chat. So the OAA funds many services, which we'll go into a little bit more on the next slide, but some general categories are caregiver support, help with transportation, preventing elder abuse, help enrolling in benefits programs that you might not know you're eligible for. They help with nutrition assistance, job training, and community centers. So there's a lot of issues that older folks are dealing with as they age that we know about, but this is really what the OAA focuses on. It just focuses on making sure people have what they need to stay at home for as long as possible. So we can go to the next slide to see some of the other core services that the OAA provides. So I know what comes up a lot of times, housing affordability comes up, and housing definitely comes into play around the Older Americans Act, and things like discrimination in healthcare often comes up when we're talking about people living with HIV and LGBTQ folks. But this is really kind of outside of that institutional space of things like housing, long-term care facilities, hospitals, and things like that. This is really all about the home. So all AAAs must provide, at the very least, 5 core services: elder rights, support services, health and wellness, and nutrition assistance, and caregiving. But AAAs are also allowed to, and often do, provide and coordinate services that are, outside of these categories. So in the elder rights realm, AAAs and service providers coordinate fraud and prevention, as well as abuse prevention, as well as long-term care ombudsman programs. So this is the one space where the OAA actually does lean a little bit, or at least overlaps with the long-term care space. Long-term care ombudsman, for those that don't know, because it is a pretty unknown position for folks outside of this policy space, they're advocates for older people and for people with disabilities who live in nursing homes, assisted living, any institutional care setting. And they help people understand and exercise their rights for quality care in a good environment. So they act on behalf of residents to ensure that rights aren't being violated, to identify and investigate complaints, and then they also mediate those complaints with residents, family, staff. They also do a lot of education around educating residents, family, staff on the issues that are experienced, and then they refer complaints to outside agencies when it's outside of their scope. And then the supportive services bucket, that includes, but is definitely not limited to, providing information on services in your area and referring you to them, as well as in-home services like personal care, housekeeping, friendly visiting, and care management or chore assistance. They also help with transportation they can also help with transportation through things like subsidized buses. For me, I'm from New York. We have something that's called Access-a-Ride here. It might be called something else in your area, but when you see those subsidized buses for older folks, that's the kind of thing that they fund. They also help with case management, maybe modifying your home to be more accessible and prepared for natural disasters. They also, like I said, help with enrolling in benefits and with legal services as well. And then there are also, under the health and wellness umbrella, provide chronic disease self-management support through training, for participating and running public health campaigns, and then also providing classes for physical activity. And we're going to come back to that a little bit later, because I know that there's a lot of overlap in the importance of chronic disease self-management programs. And then caregiver support also includes helping with respite, which is basically a short-term relief for a primary caregiver to prevent burnout, also training new caregivers, and then offering caregiver support groups and counseling. So many of you may be familiar with Meals on Wheels, which provides home-delivered meals to homebound folks, but nutrition assistance under the OAA also covers congregate meal services. So at the Sage Centers in New York City, we provide breakfast and dinner services to LGBTQ plus elders in New York City at all of our centers. So it's not just home delivery, but also, congregate meals, which also kind of overlap with that social engagement and making sure that we're reducing social isolation so people really have a community. We can go to the next slide. So now that we have a sense of what the OAA actually does, I want to go back to the history of it. So for the first time in 2020, the OAA reauthorization, or the update to the bill, required that state units and AAAs have to do three things. They have to engage in outreach to LGBTQ plus older people. They have to collect information on their needs, and they have to collect information on if they are meeting those needs. And then you can go to the next slide so we can talk a little bit about the regulatory update. So then in 2023, ACL, remember our Federal Department of Aging, announced that they would be updating their regulations that govern the implementation of the OAA. So they hosted a public comment period last year, and many of the people on this call I know helped submit comments. And Sage worked to get over 300 comments submitted through our portal that were specifically talked about the needs of older LGBTQ people and older people living with HIV. We helped call for, in updating that definition of greatest social need, which we heard about earlier, about the need for services that need might be caused by something that isn't economic. So where your geographical location is, if you speak English as a first language. And then earlier this year, in 2024, ACL released their final rule, and they updated the definition of greatest social need to include older people living with HIV, as well as LGBTQ people. So that was really a big deal for our communities. The regulations are ACL's interpretation of the law. And as states implement the OAA, they have to look to ACL's interpretation, and serving people of greatest economic and social need is really one of the basic tenets of the OAA. So we'll dive into this a little bit more later, but I wanted to share this in the context of the OAA's history. We can go to the next slide. So now that we look ahead, and I will also remind folks that these slides will be available later. I know this slide has a lot of content and it might be hard to remember all of these things, but we're going to share them later, so don't worry. So like I said, the OAA is reauthorized every 4 years, which means it's set to be reauthorized this year. So I want to share some of Sage's priorities that we're working on. So while we're LGBTQ people and people living with HIV are defined as populations of greatest social need in the recent regulations. They're not defined in the statute or the law. So the difference is that regulations are hard to change, definitely. They require a long process of drafting a new rule, getting public feedback, and then releasing the final rule. And so they are hard, but laws are far more durable. Laws are far more durable. So we don't really know what a future administration might do the next time the OAA's regulations are updated. So updating and codifying the definition of greatest social need in the reauthorization process is a lot harder, but it's a lot more long lasting. So some of the other priorities we have are adding HIV to the routine health screening list, updating the definition of family to include families of choice, including HIV in the list of chronic diseases under evidence-based health promotion programs, including and requiring the coordination of with Ryan White programs and other HIV case management programs. And then also, as we come back to this, we're circling back now. We want to update the definition of older individual to mean over the age of 40 for people living with HIV. So remember that I said earlier, OAA programs, unless they're tribal aging programs, are only available to people who are 60 and up. But we had a question in the chat earlier about accelerated aging and needing services maybe earlier than somebody who is HIV negative might need services. So we want to advocate to have older individual mean over the age of 60. We also want to establish an Office of Sexual Health, co-create a national plan in consultation with the Health Resources and Services Administration, or HRSA, and then establish a long-term care bill of rights for people living with HIV and LGBTQ plus people in coordination with the Centers for Medicare and Medicaid. And there are a lot of other priorities. We'll talk about them in our session next week. But we really wanted to just kind of give a little overview of these. So if you're interested in being involved with the reauthorization process, or you have questions about our priorities, you want to know all of them, please contact us. We'll be sharing info at the end of the presentation, but you can always ask questions either in the chat or at advocacy@sageusa.org. So I'm going to pass it back to Terry to chat about the OAA in an explicitly HIV context, but I'll be back later for our activity. Thanks, y'all.
Thanks, Emma. So as this webinar suggests, this is about demystifying the Older Americans Act as it relates to the HIV community. So what we're going to talk about now is, what does this all mean for people aging with HIV? So just to give a little bit of context here, in 2021, persons 50 years and older accounted for over 53% of all people living with HIV in the United States. And by 2030, persons 50 years and older will account for 70% of all people living with HIV in the United States. And right now, when we look at the latest Centers for Disease Control and Prevention surveillance reports, more than 2% of new HIV diagnoses are made in people 65 and older. And that we know that the older a person is when they're diagnosed, the more likely they are to have advanced HIV disease. So more than a third of older people with new HIV diagnoses have an AIDS diagnosis concurrently. So why does the Older Americans Act matter as it relates to people living with HIV? Well, there's a major area of concern for many older people living with HIV, including worries around food and housing. Many people have food and housing insecurity, meaning they don't have enough or they can't afford those. And they have concerns around the management of their finances and their healthcare benefits. So the Older Americans Act programs help address many of these. There's benefits enrollment centers that help people understand what public assistance they're eligible for. They'll help them through enrolling for these programs. And they also, as Emma mentioned earlier, offer free and reduced meals at community centers and deliver to homebound elders. Social isolation is another area of concern in the HIV community. We know, particularly from the ROA study, the Research on Older Adults with HIV study, that older people living with HIV are more likely to be socially isolated. So Older Americans Act programs help fund senior-centered programs that have support groups and activities for people to gather and meet one another and engage one another. Not all senior centers have support groups specifically for people living with HIV. So that may make folks not feel as comfortable being public about living with HIV in certain spaces. But this is certainly an area where in your own community, you could start advocating for programming to be available through these senior center programs, specifically for older people living with HIV. Another issue is that older people living with HIV have higher rates of frailty and falls. One program that the OAA funds is programming to help prevent falls through home modification and exercise programs. We know that HIV stigma is certainly present, and there's stigmatizing beliefs and or fear of stigma keeping people from getting tested for HIV, getting linked to or having access to HIV care, staying in care, accessing medications, and taking their medications correctly. So the OAA programs help address it through their long-term care ombudsman programs, which Emma spoke to. There's volunteers and staff that oversee facilities, monitoring for abuse and neglect, and distributing Know Your Rights guides to all residents so that they know what their rights are and how to contact an ombudsman if they feel like they're being treated inappropriately. These guides often don't mention HIV as a basis of discrimination, but if they did, more people would know what they're protected against and staff would be aware of illegal actions. So here's another area where we can work together around advocacy to get that added. And finally, chronic disease self-management. You know, the issue is that aging with HIV brings an increased risk of other health conditions, including cardiovascular disease, diabetes, renal disease, and cancer, among others. The Older Americans Act programs address this through what's called a chronic disease self-management education program that's provided to older adults and adults with disabilities with education and tools to help better manage chronic conditions such as, like I said, diabetes, heart disease, arthritis, chronic pain, HIV, and depression. There are over 30 of these programs available, and they're most widely disseminated and available through the Self-Management Resource Center suite of programs. There is a program specifically for people living with HIV called the Positive Self-Management Program, where it helps build confidence and ability to manage health, navigate medication adherence, and maintain active and fulfilling lives. And there's currently efforts underway to update these self-management education programs to better address the needs of older people living with HIV and the different issues that they face. So now I would like to introduce our next speaker, Andrea Callow. Andrea is the Senior Advisor of HIV Policy at the Administration for Community Living. Andrea has been in health care policy and advocacy for more than a decade. And prior to joining the Administration for Community Living, Andrea worked in national Medicare and Medicaid advocacy and legal services. So I'll turn it over to Andrea.
Hi, thanks so much, Terry. Again, I am Andrea Callow. I'm with the Administration for Community Living. You've already heard a little bit about ACL so far, and thanks so much for getting us started, Emma and Terry, with that really amazing overview. Next slide. So I don't have much to build on in terms of sort of Emma's great summary of ACL's mission and the Older Americans Act mission. One thing I will mention is that ACL serves a leadership role within the Department of Health and Human Services. That's the Federal Department of Health and Human Services. We advise the Secretary and other aging and other agencies within HHS on all things aging and disability policy. So obviously we administer funding and programs like the Older Americans Act. We establish national priorities and policies. We provide program leadership, technical assistance, and we disseminate and influence best practices. We're also advocates for the people we serve, people with disabilities and older adults. And a little plug, we fund the National Resource Center on LGBTQ aging, SAGE. Next slide. So we started already talking a bit about the final rule and an update to the definition of greatest social need. We received a ton of comments from the community. Thank you so much for those comments. And we were really happy to be able to include LGBTQ plus individuals and older adults in our definition of greatest social need now. For any of you who have been following this issue, you may have heard in the past people with HIV cited as a population in greatest social need. And that is actually true. In our 2021 state plan guidance, we did indicate that people living with HIV were greatest social need population. So that state plan guidance was exactly what it sounds like. It was guidance to states around their state plans, which I'm going to talk to you a little bit more about. So you have sort of the statute at the top, the Older Americans Act. Then you have our regulations, the final rule, and then you have guidance. So guidance was coming in kind of below the force and effect of law that our regulations had. So now by codifying this greatest social need population in regulations, we have expanded it and applied it not just to state plans, although it does still apply to state plans, but to the entire Older Americans Act rule. And as Emma said, this really affects all levels of Older Americans Act policy, all the way at the top to the reports that we at ACL have to give to Congress, down to the way area agencies on aging are contracting with community-based organizations and providers. Next slide. So one thing that's really cool about the Older Americans Act, which I think makes it pretty different from, say, another Great Society program like Medicare, is this opportunity that individuals, the public, and advocates have to get involved with the planning and the funding of services, the planning for what that funding will do and how those services will be provided. And a big part of that, and a good way to start, is to talk about the state plans on aging. So we learned about the state units on aging at the state level. These state units produce multi-year state plans, which are essentially blueprints for how they're going to administer Older Americans Act services. These plans contain goals, objectives, strategies, outcomes, and performance measures for how they're going to deliver on those goals and objectives. And we really want them to be grounded in data, qualitative or quantitative data. They also include, either described in the state plan or as an addendum, the intra-state funding formula. So this is a formula that's set out in statute. It's set out in the Older Americans Act. It is pretty complicated, but it takes into account essentially the number of older individuals in a state or in a locality, and it also takes into account how many people are in greatest economic and greatest social need in an area. The state plan should detail how greatest social need is defined, giving, some color to what we have put in the statute and in the regulations, how it's going to target its advocacy and its service provision to those in greatest social needs. So state units on aging do have an advocacy mandate in the law on behalf of older adults. And these plans are not developed in a vacuum. They are done in consultation with stakeholders, older adults in the state, area agencies on aging or their associations if they exist, and the ACL regional administrators. The regional administrators are really deeply involved from the beginning in the way the state plan is built and ultimately its approval. Next slide. So here are some dates. I just put these up here. I mentioned that state plans come in multi-year cycles. Oftentimes they're 3 years. So we have a couple of state plans due in July, a couple of state plans due next July. They will go into effect in October. I will say right now, every single state and territory is looking at their state plan. And they're thinking about how they have to amend or change it based on the new regulations. So you don't have to be one of, these state plans on the left in July to be looking at your state plan or thinking about how you're going to update your state plan. They all have their state plans open and are trying to figure out what they need to do to come into compliance with our rules by October 2025, which means for any advocates that want to get involved in the state planning process, now is a good time, irrespective of where in the cycle your state plan is. Next slide. If you'd like to find your state plan and your state unit, you can do so online. Advancing States, which is essentially the trade organization for the state units on aging, keeps this handy map up, and I have included the URL. Next slide. And also I mentioned the ACL regional administrators. They're great resources. I think they've spoken on SAGE webinars in the past. I meant to mention SAGE did a really fantastic webinar on LGBTQ plus inclusive state planning that featured some of our regional administrators. A lot of the advice in that webinar applies in this context, and I would really refer you to it as a resource. Next slide. And here's an example of how the provision of services for people living with HIV is finding itself into current state plans. So like I said, since 2021, we've been requiring states to include people living with HIV in their state plans. And so here we have Oregon looking at improved data collection to make the services it's currently providing more HIV inclusive. We also see them seeking to increase outreach to the community to improve uptake of Older Americans Act services for people living with HIV, which is great. Next slide. Here's Missouri. I thought this one actually was quite interesting when I heard Sage mention that, I heard Emma mention that for the Older Americans Act reauthorization priorities, one priority they identified was better coordination between the Ryan White program and Aging Services, Older Americans Act services. And so here we have Missouri looking to create a referral process between their Bureau of HIV, STD, and Hepatitis and DHHS, which I'm pretty sure is their Ryan White Part B, and community-based organizations or AAAs. So that bringing together what we know is somewhat siloed HIV services infrastructure and aging services infrastructure. And then also, you guys have already heard about evidence-based disease prevention programs. So for diabetes, the positive self-management program, falls prevention. Missouri wants to require its 10 AAAs to offer these evidence-based chronic disease self-management programs that would be relevant to people living with HIV. And really, a lot of those programs are relevant to people living with HIV. Next slide. So an area plan on aging, and I'll move through this, is a lot like a state plan, but it's for a particular planning and service area. It's for that region and for that AAA. So for, New York City or Metro Chicago or Des Moines, it's for a region. It is approved by the State Unit on Aging. Again, we learned that area agencies on aging can receive federal money, state money, so it has both federal and state requirements. It too must take into account stakeholder input, advisory council input, and it needs to focus on those in greatest economic and greatest social need. That includes, of course, now people living with HIV. Next slide. To find your local area agency on aging, you can go to the elder care locator. We have a phone number, also eldercare.acl.gov. Next slide. And here's an example from a AAA in Detroit, Michigan, who is doing an innovative project for older adults living with HIV in the area. So currently, the DAAA has a team member sitting on a Southeast Michigan HIV and AIDS Council, which is the Ryan White Part A Advisory Council. The agency is also implementing this really cool food and friendship connection program. We had a webinar on this a couple weeks ago, or maybe a month, about social engagement, social isolation. So this provides hot or frozen meal delivery, wellness checks, networking events, transportation to medical appointments, and just can serve as a social hub for older adults living with HIV in the area to get together. Next slide. If you're trying to decide, you've got limited time and resources, whether to get involved in area planning or state planning, there are a couple of considerations. Obviously, the timing cycles. As I said, now is a great time for both, but in other times, you might have to look about years when one is up versus the other is up. The other is the desired impact or scope. So obviously, area agencies on aging will have a more limited scope, while state units are going to be statewide. But whichever you choose, they are going to inform one another. So area plans must inform state plans, while state plans will inform area plans. So either one you choose, you're getting the job done. And then, of course, there are local and regional differences in states, different political and policy considerations. So if the state capital, feels like it might be far away, you can sort of do your work in your own community. Next slide. Here is our website. We have a webinar June 27th, where you can get a very deep dive into state plans, area plans, and that funding formula I mentioned. So acl.gov/OAA rule is where you can see everything coming out from ACL. And if you, you are a resource to us. So please, whether at the state, local, or federal level, if you have information you want to convey to us about technical assistance you need or information we should understand, policy information, please reach out and let us know. Next slide. Okay, thanks.
You should be unmuted, Terry.
Okay, can you hear me?
Yes.
Okay, fantastic. So now we're going to move on to, I guess, what we hope it will be a little break in the delivery of information that is going to get you as the audience more involved. So we're going to give you a program, and you're going to tell us if it's funded by the Older Americans Act or not. And so I'm going to invite my colleague, Emma and Cam, to help with this.
Thanks, Terry. So I am going to put a few programs on the screen, and then I'm going to launch a poll. And then after folks think about it, we'll give you a little bit of time to answer the questions. And then after everyone's had time, we'll reveal which one, the fun little animation, which ones are OAA programs and which ones are no AA programs, which I guess doesn't really make sense, but OAA or no AA is the name of the game. So first, we have a Know Your Rights guide for people in long-term care, distributed by a volunteer long-term care ombudsman. We have Medicare. Is it OAA or no AA? A weekly support group for people who are older than 60 living with HIV at a senior center, OAA or no AA. Assistance in helping make your home more accessible as you age through things like modifications or repairs. And then the last one is Social Security benefits. And kind of the purpose of this quiz is just to see if folks kind of get the whole what the name of the game is with the OAA, because we know there's a lot of other issues that face older folks in this country, but they might be addressed by other government programs and not necessarily the OAA. So I'm going to launch the quiz, and folks should have a little pop-up where you have each of these 5 questions. And we'll give it a little question. I should have added the Jeopardy music like I did. I don't know if y'all ever did that in like high school. My teacher would always make a little board and then just audibly sing Jeopardy, which I am not going to subject you all to. Okay, I'm seeing the questions coming in. Okay, I'm glad to see that a lot of people are very much so paying attention. And don't forget, if you you might need to scroll down to see some of the questions. Maybe you might only see the first few questions. Just don't forget to scroll down. Oh, yes. And then I did see that there's a change in number 4, and you're right. So number 4 says in the quiz, says assistance in preparing your home for a natural disaster, but it should say assistance in making your home more accessible as you age through things like modifications and repairs. So pretend that it's not about natural disasters. And if you've already answered, then that's okay. Nobody's actually getting graded. And yes, we will be sharing the answers after. I think I'm going to actually start revealing. So Terry, do you want to take us away? A Know Your Rights guide for people in long-term care distributed. What is it? OAA. What about Medicare? No AA. About a weekly support group. And then home repairs for accessibility, not for natural disasters. And then Social Security benefits. So I'll share the results right now. So folks should be able to see their results in that pop-up. And most people got all of them right. But it's okay if you didn't get them right. The OAA is definitely kind of a complex, very unknown piece of legislation. And why we had this quiz is because we know that there are a lot of programs that maybe should exist, as we saw in the chat. Yeah, so we know that some programs can be funded by the OAA, some programs can't be funded. So it's really important for us to kind of understand that while there are a whole host of issues that affect older people, the OAA is really just about these things and these home and community-based supports, so that people don't have to enter long-term care. Which I will also add that the caveat, just because I work on a lot of OAA work doesn't mean that that's all of SAGE's advocacy. We do work a lot in the housing space, and in fact, we have a whole housing advocate position. And we do work in a lot of other spaces that folks have talked about in the chat, but just for the purposes of today, we're just talking about these things. And then another thing that I should add, for the other question, for things that should be OAA, even if they're not currently, although a weekly support group actually could be, for people living with HIV, that could totally be funded by the OAA, is that the OAA actually makes up a very, very minuscule part of the federal budget. So it's pretty underfunded program. And so that's also why, they might not, as many programs as we'd like, might not be available. Okay, so I'm going to pass it back to Terry.
Great. So thanks for that review and that quiz, Emma. So now I am going to invite my colleague Cam, because we have a little bit of time, probably about, I don't know, 12 or 13 minutes to go over the questions that were put in the question tab. So I'm going to stop my share to bring Cam up to the front.
Hey everyone, I'm Cam Cody. I use he, him pronouns and I'm the Civic Engagement Coordinator here at SAGE. There are a lot of questions, so we will not get through them all, but we're going to do the best we can. And these are not addressed to specific folks, so just whoever would like to, please jump in. Let's jump in. All right. I'm a person who has had HIV for 41 years and been in the workforce since I was 19. I feel I've exhausted my work life, and even though I have no disability, I am fatigued. How do I ask for early retirement on HIV aging grounds since I have aged faster, and although I am 60, I feel like 80? Is there an HIV aging labor union? And I know this isn't directly OAA specific, but if anyone wants to jump in on this one.
I can answer it a little bit. Can you hear me okay? So I've had a program now for 10 years. And so a lot of the things that we're talking about, we've been trying to implement with varying degrees of success. But this is one of the, around your retirement, this is where it's really important to start planning. There is no specific retirement for HIV. And sometimes if it's just HIV alone, if it's not disabling, or if you don't have an AIDS diagnosis, it can be really challenging to try to get benefits. So you really need to talk, and like I found that it varies from county to county, depending on what your areas on aging. Also, you're looking at tapping into federal. So there's just, when it comes to aging, there's a lot of different, like our aging services department, they often talk about like all their funding sources clash. And so you have to find out, what there are different age requirements, there are different income requirements, and so you really need to start exploring this. And what we're trying to do in San Francisco is create some workforce development, but also bodies that can help people plan for this. Some people want, because of the expense of living in San Francisco, have to go back to work because their income is insufficient. So it's really complicated, but the most important thing to do is start planning. Set a goal and look, find out what you have to do. And a lot of people don't like that when I tell them this, but honestly, it's the longer you wait, the harder it gets. So I don't know if that answers your question, but there's still a lot of things that we're learning.
Thanks, Vince. And I'll just say, I'm going to drop in the chat that link that Andrea mentioned to the Elder Care Locator to find your own AAA.
Yeah.
A lot of these questions have folks asking for, specific services that they might be eligible for. And the best way to do that is to contact your local AAA. So I will drop that in the chat. Let's see. And let's see. So the next question, and I think this might be one for Andrea. Why do some services, such as meal programs, exclude seniors who have a family caregiver in the home who is under the age of 60?
Very technical question, and I would have to bring it back to our nutrition team unless there's a SAGE expert who wants to jump in. I'd have to read the law, to be honest.
Yeah, I think I would too. My first instinct is that you should still be eligible for a meal, even if you have a caregiver at home, unless you're under the age of 60. But maybe there's some exception that I'm not familiar with, and I don't want to. There could be some exception that I'm not familiar with.
Great, and feel free to follow up if someone wants to throw their email in the chat. We can connect around these.
I also know that we have a few, just because I recognize some names in our attendee list. So I know that we don't have the chat available, but if so somebody from a AAA said that some meal eligibility requirements requires you to not have somebody in home that can provide a meal. So if you have somebody that can provide a meal, that might exempt you from access to services like Meals on Wheels. Thank you to Shannon for answering that.
Thanks, Emma, and thanks, Shannon. All right, so this next one is referring to, I believe it was sent during the breakdown of programs. So some of these sound great if you're in a metropolitan area. I'm in a rural area in the deep South. I'm in Tennessee. Can anyone address this? So if anyone wants to speak to, accessibility for rural folks in rural areas.
I can take that a little. So that is definitely a big issue that we see a lot of. That's something that we talk a lot about at SAGE when we have conversations with the Aging Network, because there is this idea that people living with HIV and LGBTQ plus older folks only live in urban areas, which we know is not true. There was an AARP study that actually found that LGBTQ plus folks, and it's actually just for LGBTQ plus folks, but they're just as likely to live in a rural area, about give or take a few percentage points, as an urban area. So that's something that we definitely have been working to dispel that stereotype, because even though our communities are just as likely to live in a rural or a suburban area, as we move into those suburban areas and rural areas, as this person pointed out, LGBTQ plus specific and HIV specific services decrease. But an example of a population of greatest social need is rural older folks, because we know folks are more likely to be socially isolated, to be farther away from services, to not have access to public transportation to get to those services. So that's been a big part of our work as a part of our advocacy to say, we are everywhere. We are in every county and city in this country. And even if, folks aren't necessarily coming out, they're not revealing their status, that doesn't mean that they're not there. So a lot of it is continually talking to providers. And Andrea mentioned earlier that we have our National Resource Center on LGBTQ aging, which is for older folks and for providers themselves. And we have a few different resources around rural specific services. And one thing that I think it was in Missouri that they did is they had like a mobile senior center. So they couldn't have just, an LGBTQ senior center in this one rural town, because then what about everybody else in all of the other rural towns? So what they did is that they had that center sort of once a month. They had programming at different senior centers around the state in more rural areas. So you might have programs like that, but it's definitely a problem in terms of having access to rural programming. But it's also a great reason to say, I'm living with HIV and I'm living in a rural area. Many of us are we're multiply marginalized, and we are living, we might be living in a different place. And, we are many populations of greatest social need within one person. And that's just one more case to make to a provider or to an advocate to say, you need to serve me and you need to reach me.
Can I say something? We are like the first generation to age into this. So a lot of people don't know what our needs are. And one of the things that what we've been talking about today, they do provide places where we can do input. It is really important that people participate in these because like in San Francisco, where all the long-term survivors, we're starting to die or pass, and we're losing a huge chunk of our history. But this really hasn't been talked about openly. And that's in California, I can tell you, but it's starting to. And so when you see these opportunities to participate, to talk about what your needs are, we just launched a statewide LGBTQI survey. This year we got like 4,000 responses, almost 5,000. But in that section, we put a section, the breakaway for people living with HIV, but not a lot of states have done that. So a lot of times when they're asking for your input, they really do need it because they just don't know that you're out there. And as Emma said, we can assume that there are LGBTQI plus and people living with HIV everywhere, but unless there's a way for you to kind of make your voice heard, it's really hard for policymakers and people who plan these things out to really come up with programs that serve our needs.
Right.
Which is a great plug to come to the third session that focuses on the advocacy side of this
Right.
stuff and how we do exactly what Vince was saying.
This is actually a very well put together webinar series. I'm really happy to be a part of it because it's just like I can see how everything is going to build. So
we'll see you all there. All right. This next one is kind of a multi-part. Do AAAs have an LGBTQ plus person dedicated working with people with HIV? Our needs are specific. Are all AAAs engaged with local LGBTQ local area HIV service organizations?
I can tell you in San Francisco, we do, but across the state of California, it's very inconsistent. And, the other thing is that people are really busy, and especially coming out of COVID, and not everybody has the bandwidth. Like just in the Bay Area, services vary greatly, whether you're living with HIV or not, or whatever, just from county to county. And so it really is, something that needs to happen. Or maybe we create national networks that people can feed into somehow if people are comfortable revealing their status or being out.
Yeah, the answer is sort of yes and no. Some do. There's one in Boulder County, Colorado, that has a specific LGBTQ program. There's one in Arizona, in Pima County, but there's a lot that don't have any staff. And that's also largely because overall, like I said, the OAA gets very little funding. So a part of our asks are also increased funding because we're already the aging network is already pretty underfunded.
Yeah.
I will say I've never, when I've brought this up to a AAA director, I've never heard them say, I don't want to do this.
Yeah.
It's always been a matter of resources or staff or data or that sort of thing.
And our HIV activists like, well, why not? But because they don't understand what you just said, it's like, these are programs, they're very marginally funded. So I don't know if I'm helping the webinar or not.
Oh my God, you are. 100%. I was going to say the same thing. Like so many of our programs, like, well, we're not working with any money either too. And a lot of this stuff doesn't require there's not a huge fiscal impact all the time.
Yeah.
No, we're so grateful to have you, Vince, as always.
Definitely. All right, I think we have time for maybe one more before we start to close out. All right, the age requirement for the OAA is 60. Is there a special condition to allow those under the age of 60 to receive OAA services connected to a population with special need?
Well, I can say I go to my provider and say, can you, like I ask, if I send somebody who's this age, are you going to send them away? Because we have had that happen. But this is where I think also building relationships is really important. And I know that for myself, when I first started, it was not always comfortable for me to go to a traditional aging services person, not person, but provider, and say, hey, this is, but through time, I've made connections, and some of them have made exceptions. I don't know how they do it for some of my clients. And this is where I think building relationships and networking outside of our HIV service provider networks is really important, because there are things that the aging areas on aging funded providers can do that we can't.
And I'll know the way that they do that, like Vince said, is by leveraging the other funds that they can get.
Yeah.
So SAGE provides programming to trans folks who are over the age of 50, not 60. And then also our SAGE Positive program is also 50, not the age of 60. And that's because we just use non-OAA funds to run those programs. And then one of the things that we talked about earlier is that folks who get tribal aging services, there was a lot of really, really strong advocacy to get that language in there that said tribal organizations decide who are elders and who are not elders. It's not up to us to decide who is eligible for programming. That's up to them.
Thanks so much, Emma. And thank you all for the wonderful questions. There are so many, and I wish we had time to answer them all. But I'm going to kick it back over to Terry to close us out.
Great. Thanks so much, everybody, for participating in the Q&A. And I'm sorry we couldn't get to everything. But just to close out, we have some resources that we wanted to share. As a reminder, we are recording today, and we can send out a PDF of the slides. So just a couple of resources. So the final rule that Emma and Andrea talked about, here is the document where you can read more about it. Here is the link below for the 2024 update to ACL's Older Americans Act regulation. Then in the middle, you'll see a toolkit that was created by SAGE. It's a local community advocacy toolkit that speaks to advocating for the needs of LGBT older adults receiving aging services. And then finally, we wanted to highlight a report that came out of Georgetown O'Neill Institute. This is from 2021, HIV policy in the United States, meeting the needs of people aging with HIV. And my hope is that they're going to update that pretty soon, since it's about 3 years old now. Also, we wanted to let folks know that, of course, LGBTQ plus people and people living with HIV have been fighting for equality our entire lives. And now it's time to ensure that we receive the care and support we deserve to age with independence, dignity, and respect. So we really want to encourage you to sign up today to become an advocate for the Older Americans Act. You can scan the QR code that is on the bottom right-hand corner, so you can keep updated. So I'm going to give people just a second to pull up their phones to grab that. Again, we're going to share these slides. And then finally, we want to invite you to join us for part 2 and 3 of the Older Americans Act webinar series. So the next one is focusing on the OAA for LGBTQ plus people, which will be May 9th from 3 to 4:30 p.m. Eastern Standard Time. And then our final webinar will be for everyone, where we're really going to be focusing on how to empower the activists in us all to advance the Older Americans Act, and that will take place May 16th from 3 to 4:30 p.m. Eastern Standard Time. And if you have any lingering questions for SAGE staff, I know we did not get to all the questions, or if you'd like to collaborate on a project with us around the Older Americans Act, you can contact us at advocacy@sageusa.org to get in touch with our advocacy team or to check out our website. So our website is on the bottom left corner, sageusa.org. And then the National Resource Center on LGBTQ plus aging website is also there, that has lots of resources on LGBTQ plus aging, but also aging with HIV. So I want to thank everyone for joining today, and also thank our interpreters today. I'd also like to thank all of our speakers, Emma, Andrea, Vince, and then also a special thank you to Cam today for moderating our Q&A. So thanks, everybody, and we hope you have a good rest of your week.
Thanks, everyone.
Thanks, everyone.